It's my pleasure to be here. Thanks to you. Thanks to getting it to invite us. So this topic nowadays is very complex. My conflicts of interest, nothing relevant for this presentation. So we are in difficult times because of the publication of 2 papers, and also we know about the results of another one that is giving us negative results. This is the ART trial, recently published in JAMA, and this is the paper EpiVent from Danny Talmer, and testing the idea that recruiting the lung and giving high PEEP based on esophageal pressure could help us. And these studies provide some very difficult information for our interpretation. So the 3 studies were negative, and I'm going to talk also about the Farlap study that was not yet published, but was announced in some meetings. And then, so these 3 studies, they had almost the same entry criteria, and then different strategies of setting PEEP, and the number of patients enrolled was big enough, but all of them, they gave us negative results. And to make things worse, the ART trial had a significantly worse outcome related to the high PEEP strategy. So this reminds us a little bit about what happened 10 years ago. By the year 2009, we had the results of these 3 studies in which we were testing low versus high PEEP strategy, a kind of strategy based on PEEP FiO2 tables, except for the Express study, which was a little bit more based on the lung mechanics, but basically the 3 studies, they were very negative also in conjunction. And then, so in fact now we have 6 studies that are giving us a negative message. So how can we move forward in this subject? So this is a little bit depressing for the ones that have performed some physiological studies, like myself. And then this led us also to a kind of attitude, and this is spread around the world. So this line is the PEEP FiO2 table, the low PEEP FiO2 table proposed by the ARTSNet. This is the high PEEP FiO2 table proposed by the ARTSNet, and this is what physicians are doing. So they are not even using the low PEEP FiO2 table. So this is based on the LungSafe study. So I think these repeated negative results, they are giving us the wrong message. However, it's important to note that there is some light at the end of the tunnel, and some positive clues are around. For instance, this paper published by a single center, I was part of this study, shows us that in patients with acute respiratory failure after cardiac surgery, and when they had severe hypoxemia after surgery, when they are enrolled, and then we apply a recruiting maneuver, and we know that these patients, they have lung inflammation, there is a cytokine storm in these patients, we can have a positive outcome when we do recruiting maneuvers and appliance of PEEP, higher PEEP in these patients. We have a shorter length of stay. We had less pulmonary complications when we applied this strategy, and so in all the grades of pulmonary complications, we have some decrease in the number of patients with more severe complications when we apply this strategy. This was extremely significant. And there was some very good signals that we could recruit and reverse the basic process of atelectasis that these patients, they had at the bedside. In some patients we had EIT, and we could prove that the patients were recruited. And then this led us to have a lower incidence of use of oxygen in the 5 post-operative days. So this means that these patients have persistent atelectasis after the surgery for 5 days. After physiotherapy, after non-invasive ventilation, so this is kind of surprising and it's very insightful. In the animal area and in the experimental area, so the recruitment strategy has a very strong rationale. And provided that you can recruit the patient and you can decrease the driving pressure of these animals, and this is an experiment performed during 48 hours, you have a huge alteration in the pathological process. So in these animals, we produce the lung injury by promoting VILI, ventilator-induced lung injury, for 3 or 4 hours. So we have severe lung inflammation. And then we apply protective strategies for 48 hours. So in the animals that we apply low tidal volume and low PEEP strategy, we have persistent inflammation. And when we apply recruiting maneuvers and reversal of atelectasis and producing low driving pressures, we have a much better result in terms of histology, but especially in terms of lung fibrosis. Interestingly, even during 48 hours of mechanical ventilation, the production of lung fibrosis, early lung fibrosis, which is causing some thickening of the alveolar septum, is very prominent. And then we can reverse this by applying protective strategies with high PEEP, recruitment, and low driving pressures. And finally, now we have a series of studies showing that the PET is also telling us that the inflammation in PET after 24 hours of mechanical ventilation is also very different if you apply a recruiting maneuver with low driving pressure. So this is the results of some recent experiments, and the message is very clear. If you apply low PEEP and a little bit higher driving pressure, so this is the animals with low PEEP, and this is the animals in which you apply recruiting maneuver and low driving pressures for 48 hours. The interesting point here is that you have exactly the same tidal volume, 6 mL per kilogram. So we are back to this point, so I think this seminal paper from Webb and Tierney is still valid today. And if you remember, the difference between these two lungs is just because here we applied kind of PEEP level, keeping the same plateau pressure. And nowadays we have the proof that not only this, if you have exactly the same tidal volume, but you have lower driving pressure here, you could have much less inflammation like in this study. So, and this is very consistent. I have never seen a study that told me that this is not valid. So, and then the big question for me is that why it's getting so difficult to prove that this strategy works for humans. This is very important because when you have a very consistent physiology behind, it means that some problem with implementation is happening. And this is what we have to understand. If I had any clue that the recruitment was causing a bad problem in the animals, a worse outcome, then we should think a little bit different. And it's interesting that all mammal species, they suffer from VD and they respond to recruitment and appropriate PEEP strategy. So this brings us back to 20 years ago. So by the years 95 to the year 2000, we were in trouble with these results. Maybe you were not aware about this, but I was living this very hard process because we had this study showing that reducing tidal volume was improving the outcomes, but then at the same time we had 3 studies publishing the following years and with a higher number of patients showing that by reducing tidal volume, mortality was kind of increasing. So this was hard time. And then finally, and it was a very bad score, and then our study had a much smaller number of patients, but finally we could get the data of these trials, and then when we plotted everything together and we combined the results, we could show that in fact the real pressure and the real strategy applied to these patients was related to mortality. This was pretty much in line with physiological studies of this time. And then finally, after a strenuous work, the ArtsNet proved that high tidal volume was bad. So, you know, we have to be patient because sometimes to prove a physiological concept takes a long time. And because the bedside physiology is not easy and is bringing us lots of confounding factors that makes the evaluation very hard. So, and one of the problems is this. The devil is in the details, and especially for mechanical ventilations. And then sometimes what we believe we are doing at the bedside is not absolutely true. So, for instance, this is the ART study. And one of the hypotheses of the study is that lower driving pressure should improve the survival. And then we got a lower driving pressure in the treatment arm. But the real question is that, is this meaningful? Because in fact, this effect size was very small. The hypothesis of the study is that the difference in driving pressure was -4, and this was just -1. Just a difference of 1 centimeter of water. Just for your comparison, the ARMA study, which was positive, had a difference of -8. And our study from 98, a difference of -14. So, and this is why we can get a positive trial, but having -1 gives us a very low signal to capture in the middle of the noise you have at the bedside. And this is the result in some physiological studies in patients. I have more than 100 patients here. And then we can show that if you do a careful titration and a careful recruiting maneuver, you can get a reduction in driving pressure of 4 centimeters of water. So this is what we aimed, but we could not reproduce in a multi-center trial. Recently, we published this study in anesthesiology in which we took patients with very high chances of atelectasis, patients submitted to laparoscopic surgery. And then we showed that when we use EIT to individualize PEEP, we could prevent massive atelectasis caused by conventional PEEP. Conventional PEEP here was 4 to 5 centimeters of water. So if we detected lung collapse in EIT and we used enough PEEP to prevent more than 5% of lung collapse, we could avoid atelectasis in the postoperative phase. Interesting enough, this CT was taken 1 hour after extubation, after massive physiotherapy. So, which means that these patients, they have persistent atelectasis for days. And then, interesting also, the driving pressure during surgery was reduced by 6 centimeters of water. So, when the patient has a very high tendency to have atelectasis, recruiting maneuvers and appropriate PEEP can be very effective to reduce driving pressures. But one important message of this study, and this is why I'm showing here, is that when you take optimum PEEP detected by electrical impedance tomography and body mass index, there is a very nice correlation. The bigger the patient, the higher the PEEP they need. So for the body mass index of 35, you need an average PEEP of 30, and this is normal lung. But the important message here is this. Look at this, the spreading. So for a patient with a body mass index of 27, 28, you can have an ideal PEEP of 7 or an ideal PEEP of 17 or 16. So how come you can just choose a number by a table or something that is not individualized to set PEEP for these patients? And you can imagine that a patient like this, if you apply 17 of PEEP, it's going to be a disaster. So I think the big message that is coming from physiological studies is, if we want to apply a PEEP strategy, we have to individualize and to titrate very carefully, because PEEP is a very dangerous therapeutic maneuver, because depending on the PEEP level you apply, you can make things much worse or you can be absolutely insufficient. So you have to respect the specific individual physiology. And one very interesting message here is this. Look at this. This is how much I can reduce driving pressure by optimizing PEEP. And this is body mass index. Look at this. Patients obese are the ones in which I can optimize the most the PEEP strategy, achieving -8 in terms of reduction of driving pressure. This is the same signal we got in the ARMA study, testing low versus high tidal volume. So this is a big effect. And then some recent trials have explored this signal. This is very obese patients, body mass index of 72, for instance, in this case. So this patient had let's say, assumed ARDS because of oxygenation. I'm not sure, because just a mild lung inflammation is going to cause lots of atelectasis in these patients. And when they applied the kind of optimization of PEEP in these patients at the Massachusetts General Hospital, they got a reduction in driving pressure of -5, and they had a signal in terms of survival. This is not randomized, this is pre and post application of this strategy, but the signal is there, and all patients with 6 mL per kilogram. But this is just a signal for us that individualization is key. And then the paper of Talmor had a problem. So Talmor applied esophageal balloon trying to individualize PEEP. And as I showed you, the results were negative. So how can I explain this? For me, the problem is that esophageal pressure is not yet a mature strategy at the bedside. Why? Because the signal-to-noise ratio of the esophageal signal is very bad. Because you have to take care of the balloon, you have to take care of the compliance of the esophagus, and in a physiological study I performed in my lab, we tested different volumes inside the esophageal balloon, and take a look at this. This is a change in PEEP from 12 to 24, okay? From this to this is the signal produced by PEEP. And this is the change produced by increasing the volume of the balloon by just 1 ml. Look at this. The noise, this is absolutely noise because it's the wrong volume inside the balloon. It's bigger than the signal produced by a range of PEEP from 12 to 24. So how can you apply this strategy at the bedside if you don't know exactly how much volume you have to put inside the balloon? To put a proper volume inside the balloon, you have to perform in vivo PV curves, and this requires a special equipment. And just to make the point of how important it is to select the appropriate PEEP, this is a very easy experiment. So I take an isolated lung preparation. This is a pig lung, and I ventilate isolated without the chest wall, out of the chest wall. And then I do a PEEP compliance curve. So pay attention to this. The point of optimum compliance is a PEEP of 2, which means a transpulmonary pressure of 2, +2. If I exceed by 6, I have already half lung compliance. And if I go below +2, I start to have, below this point I have negative transpulmonary pressure, so I start to have lung collapse. So this is why when we titrate PEEP, and this is CT collapse, this is transpulmonary pressure, whenever you get below +2 of transpulmonary pressure, you start to have massive collapse and tidal recruitment. So there is a message here that if we apply +2 of transpulmonary pressure, we are going to have negligible collapse, and also we are going to have the best lung compliance, just one second. Yes, this. You have to have the best lung compliance. And how can we get this at the bedside? One of the ideas, and this is going to be my last slide because of the time. One of the ideas is that we use, for instance, a calibrated esophageal balloon with all these techniques, or we use EIT. And as you know, with EIT, we can calculate the collapse curve across multiple PEEP levels. We can calculate hyperdistension, and when we have the crossing point, and in these obese patients, for instance, where they showed this better outcome with PEEP titration, they applied an average PEEP of 21, but this produced a transpulmonary pressure of +1. So this is the right amount of transpulmonary pressure to apply at the bedside. And I think one of the compromises that the EpiVent did at the bedside was that they compromised an ideal transpulmonary pressure of +2 with some PEEP FiO2 table, which is nonsense, because if you're tracking the lung physiology, why you suddenly jump to a compromise with oxygenation that is something that is not related to lung protection? So basically, I think I stop here, and I would like to give you this message. When we are trying to apply a PEEP for lung protection, we cannot compromise. Either we believe that lung protection is key, and then you have to obey this rule, or we don't test a PEEP strategy. And I think most of the trials up to now have not followed in a strict way lung protection according to physiology. Thank you very much.